Okay, good afternoon. Good afternoon? Yeah, good afternoon. Okay, I have a tall order because I stand between you and lunch. But I also have the most topical of topics, Candida auris. And apart from that, I have to cover a few of the rarer yeasts. Okay, so let's get on, and this is going to be a high-speed train. So as you know, Candida auris did make it to the top of the WHO fungal priority pathogens list. And this is a brief summary, which most of you already know about already. It was first reported, isolated from the ear of a Japanese patient in 2009. It's been associated with many difficult to control healthcare outbreaks, and that's because it can survive very long on surfaces. It tends to be multi-drug resistant. Different clades, of course, are different. And it's also very clinically significant because in the New York outbreak, which wasn't caused by a very resistant strain, there still was a mortality of 30% at 30 days. It's very easy to misidentify, so I think it's very important for the lab staff to really be on the alert and to look out for it. And as in anything that's happening in the world nowadays, the emergence is probably related to things like climate change, COVID, supply chain problems such as the global shortage of equipment and healthcare workers. So for those interested in medical history, this is the first report, and from very early on, they have already pointed out one of the features, that it grew very well at 40 degrees. And of course, its emergence is very well known. From 2013 to 2016, only 3 US states reported it, but in the next study period, 2022, you see that it was there in so many American states. And it's also a rising threat in the EU. I think up to 2021, 11 countries had not detected Candida auris, but in 2022, I think it was in all the European countries. And what was more concerning for these authors was that the people who reported it to the authority, I think this is European CDC, were not able to tell whether it came from their own country or another country. And this meant that there certainly was the possibility of a certain degree of endemicity already. And I think you can see from the date that the COVID pandemic probably had something to do with it. I think this is already covered by Dr. Chakrabarti. The 5th clade was from Iran. Okay, I think laboratory identification is very important because we clinicians are very dependent on the lab. It is the lab that has to tell us whether this is auris or not. And in my hospital, thank you very much to people like Dr. Tan Yen Yi, who's in the audience, every single Candida isolate, even if it is from a site that we don't normally treat, like urine or the respiratory tract, is put through the MALDI machine. So we know for sure that when they say it's not auris, it is not auris. How to grow it? A variety of chromogenic agars now are able. They tell you that they can grow Candida auris, and these are the different colors. This is a very good reference written by Sharon Chen and her colleague. And like I said, it's able to grow at 40 degrees, so it is thermotolerant, and it is also able to grow in hypersaline media, so it is indeed a hardy organism. Now this is from the US CDC telling you how the different identification systems in the laboratory may mistake Candida auris, and exactly like what Dr. Chakrabarti said yesterday, when you see that one of these systems yields one of these unusual candidas, please take it out and maybe subject it to sequencing or another method of identification. So who among the colonized become candidemic? I think the jury is still out, depending on what paper you read. There are different risk factors. So on the left, on the right, is a subset study from Dr. Chakrabarti's study of ICU candidemias. They had 74 cases of Candida auris candidemia, and those were the risk factors that they found. But in Genoa, in Italy, and this is in the midst of the COVID pandemic, they also had a series of Candida auris fungemia, and they found that multi-site colonization was the only risk factor. So I think it's not all that clear who will go on to have a deep invasive infection. The ecology is still uncertain, but we all know that there is great propensity for transmission in healthcare settings and ability to survive on inanimate surfaces. Okay, so this is the first outbreak. It's from the Royal Brompton. It was first isolated from the sternal wound of a patient, and very quickly the neighboring patient got it. So I think from the word go, Candida auris hit this hospital with a big bang, telling them that it had great capacity for being transmitted from patient to patient. So what they had a reprieve for a month, and after that they had a few more cases in that same ICU. So they implemented a variety of infection control measures. And then it looked like things were better. But in October that year, they had a small spike again. And that was when they started formal infection control measures. So they had meetings, they had involvement of the nurses, the cardiothoracic ICU staff, the surgeons, lots and lots of things. I'll go through them with you afterwards. And by December, it looked like things were under control, but then by January of the next year, they had a big outbreak. And as you can see, they began to see the cases from general wards, and these were the exact general wards to which the ICU patients had been discharged. So again, showing that transmission was a big problem, and this was the case even though the Candida auris patients were put in isolation rooms, or in the UK, the term is side rooms, in these general wards. So what did they do? They did a lot of things. They did environmental swabs, and they found that positive cultures could be had from many of these surfaces and even the air. They cleaned everything with high concentration chlorine-based products, and equipment was sent for hydrogen peroxide vaporization. So you can see that in spite of doing all these things, the outbreak just went on and on in the hospital. They isolated the patients for the duration of hospitalization. They closed the affected wards and rooms to new patients. They screened contacts, and they discovered that contact was really minimal. You could just be a neighbor to a carrier for 4 hours, and you could end up being positive the next day. Healthcare workers were all asked to wear full long-sleeve gowns like CPCRE outbreak, and they even screened the staff, but only one was positive. So this is the paper that showing that Candida auris can survive for a long time on inanimate surfaces. Most interestingly, actually, Candida parasitosis can do the same thing. What they did was to look for viability in addition to culturability, and they adopted this esterase activity study to show that this thing is still producing stuff, even though you cannot culture them anymore. So we don't have time to go through that. But this is another interesting study showing that the environmental burden, correlated with the burden on the patient's skin. And these are good graphs showing this positive colonization. And their conclusions were that colonized patients carry hundreds of millions of Candida auris cells per sample. So colonization tends to be very heavy, but the colonization is not uniform. It can vary by several orders of magnitude, and I have another paper to show you that. The reasons for that are unknown. Colonized patients probably shed Candida auris continually, and that's very important, because one cleaning is not enough. If the patient stays there for a week, a month, you've just got to keep on cleaning and cleaning and cleaning. And the question they ask is whether or not if you bathe the patients daily with chlorhexidine, you could reduce the burden. So what are the best body sites? I think CDC says nose, axilla, and groin, like MRSA. So is that the answer? This is a very good study that looked at many body sites, and they found that some different sites had different fungal burdens. So the nares tended to have very high fungal burdens, but some people who were positive from some other sites carried very low burden from their noses. The ear, from where it was first historically isolated, tends to be an area of very low burden. Most of the patients they studied were in this group. So if you do, a single site like the nose, you're only going to get about 50%. But if you may have to combine, and you find that the more you combine, of course, the more likely you increase the sensitivity of your sampling process. What's the role of chlorhexidine? So in this nursing home, everybody was wiped or with chlorhexidine. Those who were invalid and those who were able to bathe were asked to bathe with chlorhexidine. But as you know, the application must necessarily be uneven. This is a very human thing. It's not a robot. But they did find that where the concentration of chlorhexidine is very high, the burden of Candida auris was very low. Now, this is a paper from PGI in India, very, very informative and educational. There were cases in this ICU, and then they did all the cleaning, but they found that they couldn't get rid of the Candida auris. And then somebody went to look carefully at what the cleaner was doing. So they found that the cleaner had this bowl of phenol, and he or she would dip the brush into this and then clean the surface, and then it goes back into the bowl. So after that, they implemented this two-bowl thing where one is just water, and after you clean the surface, you dip the brush into the water. So you clean the brush first, and then you dip it back into the phenol. But after that, they also did away with phenol. They changed their detergent. So I think we'll also look into the question of the best detergent to use if you're having an outbreak, or even if you have just a few cases. Now, this is another case. In the trauma ICU, they found that it was the BP cuffs and the ECG leads, and you know that these things are very, very hard to clean. I actually don't know how you clean a BP cuff. And they decided that maybe you could spray it with alcohol, and eventually they had to use a gas. So I think gas is best, right? BP cuff is all Velcro. I don't know how you get into all those tiny surfaces. So these are, I think, very interesting lessons as to how you would control an outbreak. Yesterday, I think there was a case of how an ECG lead caused transmission of mucor onto the skin. So I think we should be thinking of all these things nowadays. This is a list from the EPA of detergents that are approved to be Candida auris, candidicidal. I don't know whether there's such a word. Yeah, but okay. And there's a list of approved products that you can use if you want, if you're an infection control practitioner having to struggle with Candida auris in your hospital. Now, which antifungal to use? Again, very tricky. The CLSI and the UCAS do not actually provide us with breakpoints. They don't have breakpoints for Candida auris. CDC says it's important to do susceptibility testing whenever you have a Candida auris isolate. And whether there's a correlation between clinical outcome and breakpoints, that's also not known. So fluconazole, MIC tends to be high, but I think different clades are different. The triazoles, you can use voriconazole susceptibility as a surrogate, but there might be differences, so you should test them also. Amphotericin, these are what they suggest. If you have Vitek, the MIC tends to be higher, and this table has many caveats. They suggest that these are all a general guide, and the fact that the MIC is on the high side doesn't mean you cannot use them, especially if you have failed some other drug. Now, the echinocandins here are what most of the time I think people resort to echinocandins or amphotericin. Okay, now I have to move to a second fungus, and this is white pedra, trichosporin. So although it is said it's a rare yeast, it's actually not so rare in nature. It's actually quite widely distributed: soil, decomposing wood, bed droppings, pigeon. And it can cause 3 types of disease: either a superficial infection, an allergic pneumonitis, or an invasive infection. And commonly said to be second or third most common type of fungemia after Candida. And the most common underlying condition would be the immunosuppressed patients, like the patients with hematological malignancies. So 12 species have been known, and there are many subspecies or genotypes, like Trichosporin asahi has got 15 identified genotypes. So these are the 3 types of disease, either superficial infection, an allergic pneumonitis, or invasive infection. This is a Japanese group, and they found that Trichosporin is also part of the normal flora. You can get it from the gut, from skin, and from clinical specimens. Now, there are 3 series that I will go through with you. They're very well quoted in the literature. This is the first one from the MD Anderson, 17 patients, all fungimic. And, well, this is MD Anderson, so most of the patients would have leukemia. A large percentage were neutropenic, and death was very high. But back then, you will see that they didn't use voriconazole, but then it's a very old paper from 2002. Now, I think this is one of the best papers. It's from the NTUH in Taiwan. And first of all, they point out that it can be easily misidentified if you use this API. And they had to do sequencing analysis and to find that they were all different Trichosporin species. The second important lesson from this paper would be their susceptibility data. I think this is one of the first papers to show that you should use the triazole, especially voriconazole, and with that you can actually get fairly good results. And it is a fearsome infection in the neutropenic. This is the third important paper. This is from the Japanese, looking only at Trichosporin in patients with hematological malignancies. So you find that 82% had leukemia, 85% were neutropenic, and a large percentage were actually breakthroughs. So yesterday, like I pointed out, love is forever, but echinocandins are not forever. And Trichosporin in our region tends to be a common breakthrough infection for people who are already on an echinocandin. And one of the most important things for recovery is, of course, a recovery in the white cell count. It can look like candidiasis. This is a case of chronic disseminated trichosporinosis described in a pediatric leukemic patient. These are the pictures from that paper. Okay, the interesting thing is that it can cross-react with the cryptococcal antigen, and that's because it produces this antigen that shares antigenic determinants with the glucanoxylomannan of Cryptococcus. So what happened was that they used the Trichosporin begilii suspension, and they subjected it to the crypt antigen. This is an old paper, so it's the latex, and they found that yes, you can get a very high crypt antigen value. Does it happen with the LFA? Because now many of us have switched to the LFA. So this is a Chinese study. They use this crypt antigen LFA from this Chinese company, and they found that yes, so this is an in vitro study. So these are all suspensions of various fungi, and it was the 2 Trichosporin asahi isolates that produce a positive result, whether with the Chinese kit or with the IMI kit, which I think many of you are also using. This is a French study looking at the same thing, but instead of using suspensions of fungi, they use stored blood in their reservoir, in their storage, and they use all these stored blood in people with proven histoplasmosis, PCP, rhodotorula infection, Trichosporin infection, and only the 2 samples of stored blood in patients with proven Trichosporin infection produce a positive crack by LFA. Okay, how to treat? Amphotericin is not recommended. It tends to be resistant to the echinocandins. We already know it's a common breakthrough in patients who are already on echinocandins. Triazoles are associated with a very good response, and try to remove foreign bodies and vascular catheters. You can QC yourself. Somebody has already produced an equal score on how to manage trichosporinosis. So they suggest a few things. It's important to image the CNS once trichosporinosis is confirmed. They do recommend susceptibility testing, even though there are no breakpoints. Voriconazole is the drug of choice, and if you look at this carefully, there are minus marks for using echinocandin. Okay, just to whet your appetite for lunch, because I stand between you and lunch, let's talk about bread. And this is Saccharomyces cerevisiae and Boulardii. It's said to be the most emblematic of yeast used in brewing, winemaking, and of course it's used in probiotics. It's found in plants, fruit, and soil. May be a digestive tract commensal. And as I was reading, I realized that there are so many European hospitals that actually give Saccharomyces boulardii probiotics to patients to prevent diarrhea, to prevent antibiotic-associated diarrhea, or even to treat diarrhea. This Boulardii is still used in some publications, especially older ones, but it's not considered a valid taxon. It's best considered a subtype or a variety of Saccharomyces cerevisiae. And many synonyms of Saccharomyces cerevisiae have been found. If you subject them to sequencing, they're all slightly different species. Okay, so there was this Indian hospital that found a series of Saccharomyces cerevisiae fungimias, and what they found was that every one of those patients had been fed with an S. boulardii probiotic. So 2 of the patients were in their neonatal ICU, and in that hospital they have a protocol to give preterm infants Saccharomyces boulardii, but the rest were in other ICUs, but had also been administered this probiotic. Right, so basically, yeah, so this is exactly what I said, and then they took that probiotic sachet and did some testing, and they found that it actually matched the Saccharomyces that they isolated from the blood of their patients. Okay, so that was a 1 or 2 hospital study. This is a formal study. Throughout Finland, they recruited 5 tertiary hospitals in the study, and they did a case control study of Saccharomyces cerevisiae fungemia. So they found 46 cases, and they looked for controls who were bacteremic or fungemic, and had to be from the same ward, of course. And they found that 59% of patients with Saccharomyces cerevisiae fungemia had underlying diseases of the digestive tract, and the use of Saccharomyces cerevisiae probiotic was so much higher in those who were fungemic than those who were not fungemic. So the odds ratio was statistically significant. What is the incidence rate, right? So it looks as if we're going to blame the probiotic, but is there a formal rate? It's quite a widespread practice, but then you don't see Saccharomyces cerevisiae all that frequently. So this was a hospital that routinely administers this probiotic to prevent hospital onset C. diff. And basically they just mine the database of the pharmacy as well as their microbiology laboratory. And they found that 16,000 patients were administered the probiotic, so they were being fed with Saccharomyces boulardii, but only 16 developed fungemia. So it's 0.11% of all patients who were given this probiotic, and that's 1.7 cases per 10,000 patient days amongst those administered as boulardii. Okay, so now a lot of these fungemic patients do have a central line anyway, so is the central line playing a role? So they found that the incidence of Saccharomyces boulardii fungemia was 0.26 per 1,000 central line days. Now the CLABSI rate from NHSN data is 0.78, so it looks as if you have a central line and were being fed as boulardii, the central line sepsis rate was not as high. But if you limited it to ICU patients, then the incidence of S. boulardii fungemia was 0.47, and in the NHSN, I think it's 0.41. So they're trying to say that maybe you just don't blame this all the time. But on the other hand, I think there are many people who find that you hardly get it in someone who's not on the probiotic. So I think there's some host factors, and some of these may include neutropenia, the integrity of the gut, right? So I think mucositis or mucosal barrier injuries probably play a role. Okay, so this is in hematological patients. Now, this is not fungemia. They just swabbed and looked for Saccharomyces cerevisiae. And what they found was that on admission, only 1% of the patients of the fungal isolates were Saccharomyces cerevisiae. But on follow-up, 18% were positive. And they found, when they did sensitivities, they found that, it was really quite resistant. So they think that, when you give prophylaxis, and you do preemptive therapy, when you do all sorts of, give antifungals to these patients, then the Saccharomyces probably acquires resistance. But we don't have a pre and post study, because their pre was only consisted of 1 isolate, whereas the post consisted of 164 isolates. What are the risk factors that have been analyzed in the literature? There's some good papers out there, but unfortunately, as for Candida auris, the risk factors are everywhere, because we don't really have a good, large, multi-center study. So I think, as you might guess, prior antibiotic therapy, having a central line, being immunosuppressed, and then, of course, this from Patricia Munoz in suggesting that only probiotic administration was a risk factor. So susceptibility testing, this is it. Amphotericin B tends to work, but not fluconazole. Candins and modern azoles are probably all right. This is an in vitro experiment indicating that liposomal ampho probably best lowering fungal burden. What are the recommendations? They don't say much. They couch it in very general terms, saying that most of the experience is with ampho B and fluke. And there are case reports for the successful use of echinocandins, although the author mentions that there are some also lack of success. But basically, stop the probiotic, remove the central line. Amphotericin is the most commonly used, generally associated with favorable outcomes. If you look at all the unfavorable outcomes, there were patients with AIDS, cancer of the esophagus, aplastic anemia. So very difficult to tease out the impact of the fungus versus the impact of the underlying illness. Now, Saccharomyces has also been highlighted as an infection control problem in several of these papers, because they notice a certain clustering. And where am I? What has happened to me? Do something wrong. So what they found, where is this? What these investigators found was that they had a small cluster of Saccharomyces cerevisiae. So they actually conducted an experiment because these probiotics come in a sachet and have to be made into a suspension, right? So what they did was they had this pharmacist open the sachet and make a suspension of it, and then they look for Saccharomyces cerevisiae in the air, on the surface, on the hands of that pharmacist. And it was found in the air during the time of opening, but not after. It was found on the tabletop about 2 hours after. So I think after floating around in the air, it settled on the table, and it was found in the pharmacist's hands. So after that, they produced guidelines for how you would prepare the Saccharomyces. It has to be prepared not at the bedside, but far away at a proper work counter. The pharmacist or the nurse doing it would have to wash his or her hands well, must wear gloves and must wash hands. So I think those are the two rare fungi and one very topical fungus that I've managed to cover. Thank you.